All right, so let's do a quick high yield asthma review. Thank you so much, as always, for the really nice comments you guys have been leaving, the new subscriptions, the likes. I appreciate all of it. And if you haven't subscribed yet, please do. I'm coming out with new videos every week, and it really does help get the word out about the page, about the YouTube channel. So let's go ahead and get started with asthma. A couple things you'll probably already be familiar with, but it's a reversible obstructive lung disease. It's key that you know that it's reversible and not irreversible like you'll see in some other obstructive lung diseases like COPD. Generally, this is a reversible cause of obstructive lung disease. A little bit about the patho. It's an IgE mast cell mediated response in the body that leads to a few different responses. So you're going to see bronchoconstriction, inflammation, and then something known as bronchial hyperresponsiveness. So all bronchial hyperresponsiveness is bronchoconstriction in response to stimuli. So allergens, like tobacco smoke, perfume. These patients are going to have this exaggerated response that we'll see in asthmatics that a normal patient would generally have no response to. Asthma is generally diagnosed before the age of 7. About 75% of the cases. Now let's go over a few of the risk factors that you'll need to know for your vignettes to kind of help you make the diagnosis. So first, male gender. In childhood, asthma is predominantly a male disease. After the age of 20, it evens out and the prevalence is approximately equal between males and females, but in children, you'll generally see this in males. Atopy. So this is a huge one. It's probably the biggest one. Remember, atopy is a genetic tendency to develop allergic diseases, so like allergic rhinitis, eczema. It's very common in patients with asthma to have a history of these things like eczema, allergic rhinitis, for them to have this tendency to develop these allergic diseases. Family history is another one. There's components of the asthma phenotype that appear strongly heritable, and the majority of children with asthma are going to have a positive family history. And then finally, exposure to air pollution, secondhand smoke. There's some evidence that shows early life exposure to air pollution is going to increase the risk of pediatric asthma. All right, let's move on to our clinical manifestations. There's really only 3 that you need to know. Those are wheezing, cough, and dyspnea. The wheezing, you're normally going to hear that upon exhalation. The cough, a lot of times you'll hear it or see it described as being worse at night. Again, these are all things to help you in the vignette. And then the dyspnea, of course, is just shortness of breath or trouble breathing. Now, I put little asterisks there because you need to know that these 3 manifestations that you may see, they're not specific to asthma. They can occur in a number of other respiratory diseases. So what you need is your history. You need to find out when those things happen. That's what you're going to look for in the vignette. Is there a pattern of respiratory symptoms listed above that occur following an exposure to a trigger? So are they getting these things after they're exposed to cat or dog hair, after intense exercise, exposure to cold air, maybe after a viral infection? And then you're also looking to see these episodic symptoms. So the symptoms come and go for a period of hours to days, and then they're back to normal again. Those are more typical of asthma rather than some other causes. Now, in physical exam, there's a few things that you'll look for. First is prolonged expiration with wheezing. So they'll have this widespread, high-pitched musical wheezes, and they're characteristic feature of asthma, again, most commonly on expiration. They may have hyperresonance of percussion. So this is an obstructive airway disease. You're going to have air trapping. It leads to these hyperinflated lungs. So the same way when you puff out your cheek and it's full of air and you tap on it, that's hyperresonant. So the same thing here. They have these hyperinflated lungs. They're full of air. You tap on it, and you're going to have this hyperresonance to percussion. And then finally, you may see use of accessory muscles. So like your sternocleidomastoid, they're using those accessory muscles to help them breathe. Be aware that none of these may be positive on physical exam. They're only really going to be seen when they're having an acute exacerbation. So the physical exam may be completely normal because this is episodic, remember. But for a vignette, you'll probably see 1 or 2 of these in the vignette. So be aware of what you may see on a physical exam. There's also some extrapulmonary findings you should be aware of. So when you do your otoscope examination of the nasal membrane, you may see these pale or swollen membranes of the nasal cavities. You also may see a cobblestone appearance to the posterior pharyngeal wall. These are all suggestive of allergic rhinitis. Like I talked about before, this is a common condition among patients with asthma. Nasal polyps. So when you see nasal polyps right away, you should be thinking of something known as Samter's triad. So as soon as you see nasal polyps, you should be questioning them about potentially an aspirin sensitivity. So Samter's triad is a combination of asthma, chronic rhinosinusitis with nasal polyps, and an aspirin or NSAID sensitivity. This is a triad you should be aware of. In patients with this triad, after they take NSAIDs, about an hour or so after, they may develop this bronchoconstriction, nasal congestion, and you may see this triad in patients with asthma. So those are your extrapulmonary findings. There's one other one, atopic dermatitis, that you may see, just a type of eczema, itchy plaques on the flexural surfaces, elbows, knees. These things all may be seen because remember the atopy that I discussed earlier. So those are some things that you may see on physical examination. Now let's move on to diagnosis. So diagnosis, you could learn all you want about x-rays and labs, your increased eosinophils, allergy testing, blah, blah, blah. There's really only one thing you need to know for diagnosis, and that's your pulmonary function testing, so your spirometry. Now, what are you looking for when you do spirometry in a patient with asthma? Well, they may be completely normal. Again, remember, if they're not in an acute exacerbation, this may be normal. But let's go over that and everything that we do. So you do pulmonary function testing. What are you looking for to indicate an obstructive disease like asthma? You're looking for a decreased FEV1 FVC ratio. So remember, FEV1 is your forced expiratory volume at 1 second, and FVC is your forced vital capacity. So this is positive, indicating an obstructive disease of the airway if we see the FEV1 FVC ratio is less than 0.70, less than the lower limit of normal. So that indicates an obstructive disease. All right, so let's say you do your PFTs. They show this obstructive pattern, decreased FEV1, FVC ratio. It's not enough for diagnosis because you remember there's a lot of other conditions that can cause a decreased ratio with this obstructive pattern. So what do you do next to ascertain a higher degree of confidence that this is indeed asthma and not some other obstructive cause? Well, you do something known as a bronchodilator challenge. So this is a test to confirm the diagnosis of asthma in a patient with positive PFT showing that obstructive pattern. So what do? You administer albuterol or another quick-acting bronchodilator. You give them about 2 to 4 puffs. Then you repeat your PFTs, your spirometry, about 10 to 15 minutes later to assess for improvement. What number are we looking for here? We're looking for a significant improvement in the FEV1, about 12% or higher. And you really only think of asthma when you see the significant change or improvement in their FEV1. It's a good way to differentiate between a reversible obstructive cause like asthma and an irreversible cause like COPD, because COPD, when you give them a bronchodilator, they may improve in their FEV1, but it's going to be fairly minimal. Asthma, again, we're going to see this dramatic increase, and COPD, like I said, will probably have a fairly small increase. So you see this dramatic change in their FEV1. There's a very, very good chance that this is asthma. I won't say 100%, but you have positive PFTs, do a bronchodilator challenge, it responds. Most likely this is going to be asthma. Now, let's say you have a patient that comes in, you really suspect asthma, they fit the criteria, they have allergic rhinitis, eczema, all those atopy that we talked about earlier, they exercise, they start to wheeze, but their PFTs are normal, which confuses you, obviously. You don't see that decreased FEV1 FVC ratio. So what do you do now? Well, you provoke an asthma attack. You actually induce an asthma attack. You do that through something called bronchoprovocation testing. Using generally methacholine is the most common stimulant used. It's a cholinergic drug that acts directly on the muscarinic receptors of smooth muscle, causes contraction and narrowing of the airway, and it essentially mimics an asthma attack. It causes bronchoconstriction. So you do this in a patient you suspect has asthma, and if they respond and they have a 20% or higher decrease in their FEV1, this is a positive test, and this is likely going to indicate that they do indeed have asthma, because if you give a patient that does not have asthma methacholine, they're not going to have much of a change. Remember, these are patients that have this bronchial hyperresponsiveness, so these patients with asthma are going to have a big change in their FEV1, so about a 20% or higher decrease in FEV1 would be a positive test for bronchoprovocation testing. All right, so I know that can be a little bit confusing. So let's actually look at the algorithm here and let's do this together. So we have a patient that comes in, we suspect asthma, we do our pulmonary function testing, our spirometry. We do our spirometry and it comes back and we see an obstructive pattern. Okay, we're happy. That's kind of what we were hoping for. It has a low FEV1 FVC ratio. So what do we do next to confirm the diagnosis? We're going to do a bronchodilator challenge, see if they get better with albuterol. So we give them a couple puffs of albuterol. We check their ratio again, and we see the obstruction normalizes, 12% or higher increase in their FEV1, asthma. I'm going to put it quite simply. Obviously, this isn't 100%, but for the sake of your exams and things like that, it will be. So low FEV1 FVC ratio, bronchodilator challenge, it improves dramatically, 12% or higher. This is asthma. Minimal or no change in FEV1, not asthma. Let's keep it nice and simple. Okay, they come in, we do our pulmonary function testing. They have a normal FEV1 FVC ratio. All right, so what are we going to do now? We're going to provoke an attack. We're going to do a bronchoprovocation testing. We're going to give them methacholine. We give them methacholine. They have the significant decrease in their FEV1, 20% or higher. This is asthma. They have no change in FEV1 or very minimal change, not asthma. Make it nice and simple. Remember, again, this is not 100%, but for a vignette, for your exams, it will be. So this is basically how you diagnose, of course, with the correct clinical manifestations in history and things like that, but this is the way you're generally going to diagnose asthma. All right, so that is your diagnosis. Let's move on to a little bit more tricky things, the treatment guidelines and things like that. So let's first start with our medications. So there's a few different classes of asthma meds, but in the spirit of my reviews of my YouTube channel and my podcast, I'm only going to focus on the ones I feel like you need to know. There's a few different classes, but there's really only 3 that I think you should waste your time knowing about. So these are the main ones used in asthma. They're your SABAs, your LABAs, and your inhaled corticosteroids. These are really the main medications that are used in all of the treatment guidelines. So these are the ones that you need to be familiar with. So SABAs, these are your short-acting beta-2 agonists. The ones you'll likely hear about is albuterol and levobuterol. They're first line for acute exacerbations. They're bronchodilators, and if you remember about the beta-2 receptors, they're found in the lungs as well as some other places. And when they're activated through this inhalation of SABA, they create smooth muscle relaxation, which is what causes the bronchodilation. So those are your SABAs, pretty straightforward. Then you have your inhaled corticosteroids, the ones you'll likely hear about, triamcinolone, beclomethasone, and budesonide. So those are the ones you'll probably hear about. And these are first line for chronic maintenance. So regular use of inhaled glucocorticoids reduce the frequency of symptoms and also the need for the use of SABAs for symptomatic relief. So this is a good use for chronic maintenance. It also decreases the risk of serious exacerbations. It's a great med to be used as daily controller therapy. And of course, like all steroids, you know that they inhibit inflammation and cytokines. And then finally, our LABAs, long-acting beta-2 agonists. The ones you'll hear about, this one is probably the most likely you'll hear about. So definitely know this one, formoterol. And then there's also salmeterol. These are often combined with an inhaled corticosteroid, which I'll go over in a minute. They're used in maintenance to prevent symptoms. And then they are bronchodilators in the same way SABAs are, but they have the effect of not only just working for not working just for an acute exacerbation, but they have a long-term effect, about 12 hours or so. So they're long-acting beta-2 agonists. Now, you may wonder why I even mentioned that they have a short-acting benefit, and it's because LABAs, there's some new guidelines that are using only formoterol for short-acting acute exacerbations as well, which we'll go over shortly. So there actually is some use for acute exacerbations, specifically only with formoterol, because this has quick onset of action, about 3 minutes. So those are the only ones I really feel like you need to know. These are the preferred agents in all of the guidelines. Don't worry about your leukotriene modifiers, your montelukast, which has a black box warning now for behavioral and mood changes. They're not that effective. They're not used very often. The same with theophylline. It's rarely used. Focus on your SABAs, your LABAs, and your inhaled corticosteroids. The backbone of asthma treatment, those are the ones you'll most likely get tested on. All right, so now, and then, okay, this is the last thing I forgot to mention. You never use LABAs as monotherapy. They always have to be combined with an inhaled corticosteroid. If you use them by themselves, they can actually render SABAs ineffective. There's this downregulation of beta-2 receptors. Don't worry about why. Just know the only wrong answer in asthma for treatment is LABA by itself. You never use it as monotherapy. It's always combined with an inhaled corticosteroid. Okay, so let's move on to our treatment guidelines. These are, I mean, there's a lot. So there's multiple guidelines. They're broken up into multiple age groups. If you try to memorize it all, you'd go crazy. So I boiled it down to the bare minimum. I focused on the NAEPP 2020 guidelines, which up to date states some preference for. It's the one you'll see in PANCE Pearls. The other guideline you'll hear about is your GINA guidelines. It's the Global Initiative for Asthma. I'm not going to focus on this one, but I'll go over it briefly. The good thing is if you did get a question on it, it's super easy. It's a step up or step down approach, and it really only involves 2 medications, an inhaled corticosteroid and a LABA. So the main difference with GINA guidelines compared to most of the other guidelines out there is the fact that GINA guidelines don't use SABA as your first line for acute exacerbations, which this is, you can imagine, is controversial. SABAs have been used as first line exacerbations for over 50 years. So the GINA guidelines actually focus on using a LABA specifically for formoterol combined with an inhaled corticosteroid. So let's go over those and briefly go over the GINA guidelines first. So GINA, again, remember, Global Initiative for Asthma. These are the treatment guidelines for those. So let's take a look at this. Okay, so looking at the GINA guidelines here, again, really there's only two meds you need to know, your inhaled corticosteroids and your formoterol. It's really easy. So what you do is you start at your step one, which would be infrequent asthma symptoms, about less than 2 times a week. And then what you do is if you start your treatment here, they're not getting any better over a few months, you move it up to step two. They're not getting any better, you move up to step three. And then all of a sudden they're at step three, and then it's been a few months and their symptoms are decreasing, then you can move back down to step two. That's how it works. It's a step up, step down approach. Now, if you look at this here, you can see you have your preferred controllers, your preferred relievers, and then you have the other options. You have a million things to memorize for PA school. Why are you going to remember your other controller options and the other options they give you? Just focus on your preferred. Let's get rid of that. Let's get rid of that. So you have your preferred controllers and your preferred relievers. Now, a preferred reliever for, like I said, 50 years has been Asthma, but not with GINA guidelines, and that's why these are a little bit more controversial. This is kind of an off-label use here in the US as well. So again, I don't want you to focus too much on these guidelines because they're new and you probably won't get tested on them, but I think you need to be at least aware of them. So the preferred reliever for the GINA guidelines across the board is your inhaled corticosteroid with formoterol. Remember, formoterol, it's a LABA, but it has a short-acting onset. It starts working in about 3 minutes. So it is a LABA, but it does work fast, so you can use it as your short-acting for your acute exacerbations, I guess I should say. So remember, relievers for GINA is going to be low-dose ICS with formoterol. Now, step one and step two, they're the same. It's low-dose ICS with formoterol, same thing here. So this is just an as-needed ICS formoterol. And then step two is the same thing. You can do a low-dose ICS formoterol. So really, step one and step two are the same. You have an option here if you just wanted to do a daily low-dose ICS, but make this easy. Step one and step two are all low-dose ICS combined with formoterol. Step three, step four, step five, it's really easy. All you're doing here is you're going from as needed to daily low-dose ICS with the LABA. You can still use your ICS with formoterol as needed. And then step four, you're just increasing the dose of your ICS. So you go from medium to high. That's all it is. That's all the GINA guidelines are. All about your low-dose ICS and formoterol, and you're stepping up the dose of the ICS as you go up, and then changing here to daily use, and then this is just a higher dose of ICS. That's all it is. That's all I really want to go over on it. I don't want to go too far into this because I feel like the guidelines I'll go over next, the NAEPP 2020 guidelines, are the ones that you'll likely get tested on. I feel like those are the more important ones. So let's move on to that. So we have our National Asthma Education and Prevention Program 2020 treatment guidelines. So these were updated last year. And then these are the ones that have been used over the years for a long time. I feel like this is probably, like, of the two, the one that you'll be tested on. It's a little bit more complicated, but I do have a mnemonic for you at the end to help. All right, so there is 4 stages that you need to know about. And they advise, just like with the GINA guidelines, initiating pharmacologic therapy based on the frequency and severity using a step up or step down approach. So let's start with intermittent step 1. These patients are going to have daytime symptoms less than or equal to 2 days a week. They're going to have nocturnal awakening, so there's going to be times where they're woken from the asthma, wheezing, cough, whatever it is, 2 or less times a month. They're going to have a normal FEV1, so no change, no obstructive pattern on FEV1. And then treatment for them is SABAs as needed. That's it. So intermittent step 1, remember, daytime symptoms 2 or less times a week, nocturnal awakenings 2 or less times a month, normal FEV1, and you're going to give them a SABA. That's it. Mild persistent step 2. So these patients are going to have daytime symptoms a little bit more than 2 but less than 7, so falling in between there. Their nocturnal awakenings are 3 to 4 nights a month. And then finally, their FEV1 is normal, just like in step 1. And the treatment here, you're just going to give them inhaled corticosteroids plus your SABA PRN. So the only change here you just had SABA PRN. Here you're adding on a low dose of inhaled corticosteroids. That's your step 2. Now, step 3, moderate persistent step 3. So these patients are going to have symptoms every day, daily symptoms. Their nocturnal awakenings, they state, let me show you something here because I feel like it can get confusing. So remember, in step 1 and step 2, nocturnal awakenings were 3 to 4 nights a month, 2 or less a month. Well, the way they list it in their guidelines, they state more than 1 time a week. So they go from month to week. It just makes it confusing. So the way that I used to remember it is more than 1 time a week is 2 at minimum. And then you figure 4 weeks in a month, that would be 8 or more nights a month. So that's how I remembered it. Instead of going to week from month from the other ones, I just remembered 8 or more nights a month. That's nocturnal awakenings. And remember these because this is how the mnemonic works, is based off of this. So That's just really quick. So I remember you get rid of your week and then you focus on just 8 or more nights a month to make that easier to remember. Now, these patients do have a decrease in their FEV1, so 60 to 80% predicted. And then the way you're going to treat these patients is you're going to introduce your LABA. It's going to be formoterol. This is kind of like the GINA guidelines. So formoterol specifically, plus a low dose inhaled corticosteroid. So that's the treatment for step 3. And then when you get to step 4, these patients are going to have symptoms all day and every single night. So everything going on, it really never ends for these patients. This is severe persistent step 4. FEV1 at this point is less than 60% predicted. And the treatment for these patients, the only change from step 3, you're going to give them the same, the formoterol, but instead of giving them a low dose inhaled corticosteroid, it's going to be a medium dose. So that's really the only change there. Now there's a refractory steps 5 through 6. You're going to increase the strength of the inhaled corticosteroid. You're going to give them LAMA, like tiotropium. You're going to give them biologics. You're pretty much just throwing anything and everything at them because they're not being helped with their symptoms on all of the previous steps. So steps 5 through 6, I wouldn't really worry about. Kind of stop at step 4, and this is generally the guidelines that you'll see. Now, that's a lot of crap to know. I really don't suggest memorizing it. The only thing I would say, if you can remember my mnemonic, I think you probably will know enough of what you need to know for those guidelines. So the way that I remember all of it is that it's silly to memorize it, which it absolutely is. But if you want to, remember 2, 4, 8, and then an 8 on its side. An 8 on its side, that's an infinity sign. I'm sure you've all seen the infinity sign before. So if you remember the guidelines, it's silly to memorize it, but if you do, remember 2, 4, 8, and then an 8 on its side. So what does that stand for? Well, silly combined with the 2, 4, 8, and 8 stands for SABA, inhaled corticosteroid, plus your SABA PRN, LABA, your formoterol, plus your ICS low dose, and then increased ICS, your medium dose ICS plus LABA. And these are all according to the steps we're at. And then the 2, 4, 8, and 8 on its side stand for 2, which is 2 or less nighttime awakenings. Again, I'm only pointing out the nighttime awakenings, but the thing is, they're going to give you the nighttime awakenings, and the nighttime awakenings for all the steps are different. So if you just remember the nighttime awakenings, you don't need to memorize all of the FEV1 guidelines or the daytime. They're going to give you the nighttime, and they're all different. So just remember that one thing, and you can remember. So 2, 4, 8, and 8 stand for 2 or less nighttime awakenings a month. 4, remember the mild persistent step 2 was 3 to 4 nighttime awakenings, so you just remember 4. And then you're doubling with each one. And then 8, remember, like I said before, it was more than 1 per week, so remember that was 8 in a month. So 8 or more nighttime awakenings a month. That's your moderate persistent step 3. And then this one, this is the infinity sign, so it's the 8 on its side, because remember, the awakenings never end. There's never a stop. Every single day, every single night, they're always being awoken. So it's infinite. It goes on forever. It never stops for them. That's severe persistent step 4. So you turn the 8 on its side, and then that response to the I stands for increased inhaled corticosteroid, because remember from this step, all it was an increase in the dose to medium. And then so we have SABA 2, inhaled corticosteroid, because that was the second step. 4, LABA plus your ICS. 8, increased ICS, because we went to medium dose. 8 on its side, infinity. So it's silly to remember the asthma guidelines, but if you do, remember 2, 4, 8, and then 8 on its side. So hopefully that works for you. If you didn't memorize this, I wouldn't blame you, and maybe you'd miss out on one question. So don't go crazy with this. So those are the guidelines. That is asthma. Let's do 5 quick questions, and then we will wrap it up. Question 1. Combination of asthma, chronic rhinosinusitis, combined with nasal polyps and a sensitivity to aspirin is known as, that is going to be your Samter's triad. Question 2, what diagnostic test is the gold standard for diagnosing asthma? It's the only one we went over, so hopefully you remember that's your pulmonary function test, your spirometry. Question 3, what asthma medication should never be used as monotherapy? Hopefully you never do this in clinical practice. That's your LABA, so your formoterol, your salmeterol, they must always be combined with an inhaled corticosteroid. Question 4, a patient with history of asthma that performs a bronchodilator challenge would be expected to have an increase of FEV1 of what % or higher? Remember, you're generally looking for a 12% or higher increase in your FEV1. Question 5, what is the classic triad of symptoms seen in patients with asthma? So remember the 3 things that you may see in patients as wheezing, cough, and dyspnea. All right, guys, so that was asthma. Hopefully that helped you. Please let me know if it did. And thank you so much for watching the YouTube channel. Thank you so much again. Good luck on your PANCE, your PANRE, your EORs, and good luck in PA school.